Hello and welcome to this VetLit podcast. VetLit Minis are journal club podcasts on a range of topics, small animal focused, so you can keep up to date even if you just have a few minutes spare. Today we're going to be learning about tracheostomies in dogs with BOAS or brachycephalic obstructive airway syndrome. We have two amazing guests today, both authors of a recent study on tracheostomies. We have Professor Deborah Silverstein and Dr. Lauren Minter. Thank you so much for joining us. We really appreciate it.
Our pleasure to
Thank
be
you for
here.
having us.
Professor Deborah Silverstein is Head of Emergency and Critical Care at Penn Vet at the University of Pennsylvania, and Dr. Laura Minter is a criticalist at Access Specialty Animal Hospital, Pasadena, and a previous ECC resident at Penn Vet, where this study was completed. The study was entitled Factors That May Be Associated with Tracheal Decannulation Failure in Dogs Requiring Temporary Tracheostomy After Upper Airway Surgery for Brachycephalic Obstructive Airway Syndrome. Now, let alone the opportunity to talk about the study findings, it's actually a great opportunity just to think about our clinical practice and experiences and differences between institutions, things we don't know, things we could try and find out. Because the study itself is quite, it's quite neat and compact. Would you mind to tell us your original aims and the main findings from your study?
Yeah. So this study kind of came about just because of the number of brachycephalic patients that we saw during my residency. And of those that did end up progressing to the point of needing trach tubes, it felt like trying to then detrach them was sort of the biggest challenge. And so many of them required multiple different attempts. And it felt like there was a lot of sort of, I guess I'd say, guesswork in, what may or may not be benefiting them, what working against them, things like that. So that's a big reason why I wanted to do this study. And there's not really anything looking at decannulation in animals. There are some studies in humans. But we looked at several different factors, including like age, body condition, breed, things like that, as well as what surgery they had done, other comorbidities like laryngeal collapse, and then also some aspects of our management, with the biggest one I would say being the frequency at which we were suctioning their trachs.
Yep.
What we did end up finding is that there were two factors in this study that were associated with failure of decannulation, and those were the presence of grade 2 or 3 laryngeal collapse, and then also an increased frequency of suctioning their trach tube in the 24 hours prior to attempting decannulation.
Brilliant. And then do you think it's changed your approach to these dogs in any way? It's quite useful perhaps from owner and vet perspectives, isn't it, this information?
Yeah, I think the laryngeal collapse part of things is probably more of like a prognostic type of indicator, but it is definitely something that I now will mention to owners. If we get to the point where we've done airway surgery and they have a trach, I'll mention it as this may be something that makes it a bit more difficult to decannulate them, may worsen their prognosis, things like that. And I do think it's also kind of pushed me to start recommending earlier airway surgery in these patients rather than waiting until they're, 5 or 6 years old and have progressed to the point of having wicked laryngeal collapse. It's something where I now talk to owners about, hey, your dog is kind of loud. Maybe you should consider airway surgery at like, 1 or 2 years of age. So I think that's kind of where I'm at least from the laryngeal collapse part of
Yeah.
things. And then as far as suctioning goes, it's really hard to know whether we're seeing patients fail because they have excess secretions that are needing to be suctioned, or whether we are truly causing tracheal trauma or other problems by suctioning them so frequently, or a combination of both. Um, I do think I lean more towards trying not to suction them unless it seems like they absolutely need it and are at risk of obstructing their trach tube rather than just doing it, a certain number of times a day at baseline.
Yeah. So while we don't know if we ourselves are causing much of the inflammation and precipitating more of a more mucus secretion, you're moving away from default suctioning only in particular situations where it's semi-obstructive or worsening. Is that right?
Yeah, exactly.
And then what about the when you actually attempt decannulation? Do you have a did you have a protocol? Do you have a protocol? Is it different?
Yeah, I don't have a protocol. It's very patient specific. In this study, we found that I think the median for successful decannulation was like 50 hours post-op, so roughly 2 days. I definitely have patients where I will attempt it sooner, if it seems like they don't have a ton of airway swelling or the airway swelling has improved. They don't have concurrent aspiration pneumonia or something, leading to a lot of secretions. And then I think another big factor is what the owners are able to do financially. I
Yeah.
think a lot of times we'll try maybe a day earlier than we otherwise would if it's a situation where the owner's like, I really ideally need to get my pet out of the hospital today. But if there are patients that have a lot of other, if they do still have a lot of airway swelling, if they do have aspiration pneumonia, things like that, I lean more toward waiting like 3 to 4 days. It's
Yeah.
kind of a gut thing, if I'm pretty confident that they're going to fail, I'll usually wait a little bit longer before I try,
Yeah.
but definitely no set protocol.
See, I think you've learned that quicker than me because I still got those problematic cases where I'm trying at 24, trying at 48 and should have just waited.
Yeah, it's
I
so
think
hard to
you,
know.
I
I mean,
think
some of them surprise you and they do great when you don't think they're going to. So you never know.
it's true. And I think weighing the pros and cons, with the major con being the increased risk of aspirating environmental pathogens,
Hmm.
irritation to the trachea, and potentially stimulating more secretions, or the increased risk of airway obstruction within the trach tube itself. So it's not benign
Sure.
to leave it in longer than necessary, but finding that Goldilocks time period for decannulation is definitely challenging.
Yeah, yeah. The cases that I was hoping to think through with you a little bit more specifically are those emergency patients, the ones coming in with an upper airway obstructive crisis. It justifies BOAS surgery and they get BOAS surgery on that visit and they also have a trach or they also get a trach. Your practices in doing or requesting that trach, because we've definitely circled around this issue and sometimes we consider just saying, right, every single patient that comes in on an emergency basis requiring BOAS surgery should have a trach by default. What do you think about that? Do you ever get so far? We haven't done that, but ultimately that's what we sometimes we regret not just doing that from the get-go. Or maybe we should
Yeah.
trick them and give them a few days before even thinking about the surgery.
Yeah. I think that's another thing that is a bit patient specific and also somewhat kind of depends on the time of day. If it's 9 p.m. and they're not going to have airway surgery until tomorrow at the earliest, then I'm
Yeah,
going to trach them rather than have them sit and be intubated all night.
yeah,
And then obviously the discretion of the surgeon too. The surgeons that I work with right now lean more towards I'd like to give them a day or two for some inflammation to go down before airway surgery, which is totally fair. And so I feel like now I tend to trach more of them and have them kind of sit and wait for airway surgery. I've also seen patients that go straight to airway surgery and there's so much inflammation that surgery just makes the world of difference for them and then they're fine and don't need a trach. So I don't think we have a good answer. Again, it's patient specific, and as much as we hate to do unnecessary procedures, there are probably patients that we trach that could have been okay without it. And then there's patients that we don't trach, and then we're wishing that we did. So, yeah, it's very hard to decide, but I definitely do not have a set protocol for that either.
yeah, yeah. You bring up the topic of suctioning perhaps worsening the or inappropriate suctioning worsening the secretions, etc. And we were talking off air about this concept of a recurrent obstructive fibrinous pseudomembrane, which is for the benefit of the listeners, because there's not many of these described, but this is the situation in which you have a BOAS patient that has had recent or multiple intubations, for example, and as opposed to failing decannulation or failing breathing of its own accord due to normal anatomic dysfunction, they fail with catastrophe because they have this almost a cast inside the trachea, a coagulum of mucus and inflammatory cells that's dried out and then near obstructs the whole trachea. Do you have, because there's a few of them reported and we were discussing them on the listserv. Do you have any experiences of them or comments on that subpopulation of dogs? Because I wonder if some people listening actually have seen that, not necessarily put two and two together or not knowing what to call it, and that's what actually what they had.
Yeah, I can't say that I have seen that kind of tracheal membrane where I could say, oh, that's definitely, sloughing of the trachea, but definitely there are patients that have just kind of those big globs of bloody mucoid stuff.
Hmm.
But there is probably some level of tracheal sloughing there. And those are hard because a lot of times if we don't help them by suctioning, that's enough to obstruct their trach tube. A lot of those patients I feel like are not necessarily able to cough those up on their own. But at the same time, we know at least in human medicine that frequent suctioning and also suctioning technique can definitely worsen tracheal irritation. And so
Hmm.
sometimes I wonder if we're kind of like chasing ourselves in a circle.
Yeah.
And I don't know that we have a great mechanical solution, but we do talk about what can we do to sort of decrease or thin out at least respiratory secretions so that they're less at risk for causing obstruction. The patient can potentially get them up on their own. We don't have to suction constantly, things like that. And I think that's another thing in veterinary medicine that we don't necessarily have great methods of trying to thin out those secretions like or at least not studies on what works and what doesn't, like they have in human medicine.
Yeah, yeah.
And I will say I have seen the pseudomembranous casts in these patients, not frequently, luckily.
Yeah.
And as I think of it, the ones I've seen are usually after we've decannulated. And so
Right.
I wonder whether some of the cast formation could be secondary to the presence of the tube and or the suctioning and or trauma, inflammation, or other that has led to the creation of these casts. And they sometimes can look very much like the trachea.
Yeah.
They can alarm nurses. They alarm me
Yeah.
to the fact that it has a resemblance to the actual tracheal ring shape,
Yeah.
and they can be a little alarming. So uh, the animals that do cough these up uh, are lucky because usually they were in pretty severe distress prior, and then when this blob of tissue or secretions is expectorated, they breathe much better, and it's apparent that this was something I don't even think a suction catheter can get out because
No.
they're big, they're thick, they're heavy,
Yeah.
um, but they can be deadly.
Yeah, absolutely. Yeah. I know I like the idea that there probably is, isn't there, a continuum between really thick globs, inspissated mucus all the way through to a what looks like a real piece of tissue, doesn't it? And yeah, whether how much of that we're actually inducing ourselves with our tubes and our suctioning. That's a pretty cool concept to think about, isn't it? I think the only thing that we do differently over time now is that in these, for example, a recumbent English bulldog that has had BOAS, had a trach, has aspirated. We sometimes we don't even bother with the traditional tracheostomy tubes now because actually the problem that we have is with the dislodgement. That's half the battle for us. So we're quite often just using trimmed ET tubes. Do you see the same situation? Do you have better solutions than do we? We quite often literally just cut an ET tube down to size and use it as a little snorkel because it quite often makes actually the cot management, in a cot rather than a kennel management of that patient a lot easier as well with a little snorkel outside.
Yeah, I have definitely done that before. I find that English bulldogs, like, there's so much skin and fat
Yeah,
and whatnot that by the time you get a tube in there, it's like barely even reaching their tiny little trachea.
yeah,
Or if you size up on tubes, then maybe it can get there, but then it's, going to be a little bit big for their trachea, in which case maybe that is something that's inducing more tracheal irritation and trauma and things like that. So, as much as it's nice to have a true trach tube and have that little like inner cannula that we can take in and out and clean, I agree with you. If it's that much of a struggle, I tend to lean more towards using a cut endotracheal tube that's going to be a better fit and hopefully cause a little less trauma.
yeah.
Agreed. I think the downsides are just you have a somewhat floppy tube, or it's coming out near an ear or somewhere else, and it can be somewhat challenging to give continuous nebulization and or humidification since we're bypassing the upper airway, and that's a little of a vicious cycle itself. I think if you have a tube without an inner cannula and they're breathing drier air or drier
Yeah.
oxygen potentially, then it is going to predispose to thicker secretions that could be problematic down the road. So it's always weighing the pros and cons of these choices. Some of the manufacturers of tracheostomy tubes are trying to make them a little more customized to animals, dogs. I think we do try to use a real tracheostomy tube when we can, but I know between the depth and the angle and the redundant skin and the short neck of many of these brachycephalics, it's
Sorry.
a challenge. So I think we have to do what is safest for sure, because when trachs become dislodged, that obviously can be life-threatening as well. So
Yeah, yeah.
it's just a matter of making the best choice of the worst choices for that patient.
Right, yeah. There's absolutely a niche there for English Bulldog specific trach tube range. So anyone listening with that skill set, please email in. I think that probably brings us to the end for today. Thank you so much for joining us. Was there anything else that you wanted to convey or anything that you feel we should have pondered over?
I don't think so. I mean, I think we still have so much to learn about how to best manage these dogs. I would love for there to be larger prospective studies in regards to how best to manage these dogs with trachs. And I think we're getting there, but as of right now, we kind of just have to do the best that we can and know that they're very difficult and complicated patients a lot of the times.
I agree completely. And I think if we move forward with the two findings of this study, albeit small,
Mhm.
into larger studies looking at how to prevent laryngeal collapse by doing earlier tracheostomies in those animals. Like Dr. Minter said, the laryngeal collapse is often secondary to prolonged increased inspiratory effort. So we can help that to some degree. And then maybe also getting better suctioning protocols, where if they don't have an inner cannula, maybe we only suction within the tube itself without touching the tracheal mucosa to start. If that's not able to clear secretions or noise within the airway, then maybe we do a suctioning technique that involves a short, gentle, low pressure, like less than 100 millimeters of mercury type of suctioning to minimize the trauma we induce. And perhaps that would decrease the formation of more secretions that might predispose to decannulation failure if
Right.
it's a trauma-induced secretion. I think looking more at medical ways to thin the secretions, whether that be N-acetylcysteine, whether we use hypertonic saline and or bicarbonate or other
Right.
medications to try and break up the mucus itself through breaking disulfide bonds, um, maybe trying to prevent traching them at all with things like nebulized epinephrine or other treatments. Our surgeons are now using mannitol soaked gauze
Yeah, I've
that
seen
they
that.
put on the soft palate prior to extubation. And I think good old steroids.
Yeah, yeah, yeah.
Just there's a lot of things we need to learn still about maybe ways to either prevent the need for tracheing them or successfully getting them decannulated by decreasing secretions and or severity of laryngeal collapse. But I think if we band together and get some larger cohort studies, maybe we can find even more ways to help these poor genetic creatures.
Yeah. Yeah, perfect. So a list of studies ready to roll there. And unfortunately, there's a plethora of the cases to go between us, aren't there? Okay, well, that brings us to the end. So what I'll say for now is the aim of VetLit is to make veterinary literature both more accessible and accessed, and hopefully we've secured that in some small way today. Remember, you'll almost definitely find an article to read that interests you on the vetlit.org site. You can look back there, here, or via the email updates for more. And otherwise, have a great day. And it's goodbye from Professor Silverstein and Dr. Minter.
Thank you.
Yeah, thank you for having us.
And it's goodbye from me. Bye for now.